Good morning, sir.
Yeah.
I'm going to present the surgical audit for November 2022 for Unit 1 General Surgery. I'm Dr. Milind Aloji, third year DNB PGT, MRBH Hospital. So we had a total number of 8 OPD days and a total number of 10 admission days. Around 1200 patients were there in our total OPD patients. Total number of elective OT days was 9. Total time in the OT, in the lab OT was around 23 hours and in the open table was around 33 hours. The total number of minor OT days was 7 and the time in the minor OT was around 7 hours and the time in the emergency OT was around 4 hours. The total number of mortalities was 1. We had a single mortality in this class. We had 40 elective admissions, of which 36 were admissions that were taken up for elective operations. Around 17 emergency admissions were there, of which 7 were taken for emergency operations. Around 40 minor operations were there. We had 1 mortality and 3 morbidities. Among the morbidities, there was 1 male and 2 female patients, and these will be discussed subsequently. When we talk about the elective admissions in the hepatobiliary, pancreatic, and splenic surgeries, in the elective admissions for chronic calculus cholecystitis, we have 12 patients, 12 females who underwent laparoscopic cholecystectomy, and 1 female who had undergone an open cholecystectomy. One patient who was admitted with cholelithiasis underwent an open cholecystectomy with CVT exploration and T-tube insertion. In the GI and perianal surgeries, 1 patient who was diagnosed with periampullary CA was managed with the Whipple's procedure. This male patient underwent a Whipple's procedure. 1 patient which was a post-op case of exploratory laparotomy followed by ileostomy. This patient had come in the emergency in MR Bangalore only, and this patient had is a post case of trauma, and after an exploratory laparotomy, an ileostomy was done, and this patient underwent an ileostomy closure. This was also a male patient. 1 male patient with a fistula in underwent a fistulectomy, and 2 patients who had fissure underwent a lateral sphincterotomy. 3 patients with recurrent appendicitis underwent laparoscopic appendectomy. In hernia and groin surgeries, 2 female patients who had came with ventral hernias, incisional hernias, underwent mesh hernioplasty. 1 patient underwent a tap hernioplasty for a unilateral inguinal hernia, whereas 3 patients for unilateral inguinal hernia underwent Lichtenstein mesh hernioplasty. There was 1 young child who had come with a torsion, with a unilateral torsion of testes, and the testes had already lost the blood supply. The ischemia had set in. So this patient underwent the unilateral orchidectomy with the contralateral orchidopexy. 2 patients with unilateral hydrocele underwent a unilateral eversion of sac, and 2 patients with phimosis underwent circumcision. 1 patient with multinodular goiter underwent a total thyroidectomy, and 2 patients with fibroadenoma underwent excision. Now, among the miscellaneous elective admissions, 1 case that we had admitted, which was of special interest, was a case that a patient presented with obstructive jaundice. We worked this patient up, and this patient came with the final diagnosis that came as a common, as there was a stricture at the confluence of the right and the left hepatic ducts, and with a query Klatskin tumor, and this patient was referred to higher center for further management. Among the emergency operations, we had 1 patient with acute intestinal obstruction, and this patient underwent an exploratory laparotomy. This was a female patient. 2 patients who had come with foot ulcers underwent incision and debridement. 2 patients who had come with unilateral lower limb cellulitis with compartment syndrome underwent fasciotomy, and 2 patients who had come with perianal abscess underwent incision and drainage. Other than this, some emergency were managed conservatively. 2 patients with acute calculus cystitis were managed conservatively. 1 patient who was admitted with liver abscess was with USG guided pigtail drainage. 1 patient was admitted with a complaint of pain in bilateral lower limbs, and this patient was finally diagnosed to have peripheral arterial disease. and this patient was managed conservatively. One patient was admitted with polytrauma, fractured rib with chest complications, and this patient was managed with conservative management with ICD insertion. One patient was admitted with left foot cellulitis along with medical comorbidities, managed conservatively, and two patients who had come with diabetic foot ulcers were managed with debridement and dressing. Other minor operations and in emergency interventions. One patient was underwent a wedge biopsy from an ulcerative lesions. There was around 12 excision of sebaceous cyst, 3 lipoma excisions, 3 excision of papillomatous growth, 4 Zadig procedures, 14 cases of incision and drainage, and 1 case of foreign body exploration. Among emergency procedures, we did 1 chest drain this month and 1 suprapubic catheterization. Now I will discuss the morbidities and the mortalities that we had in this month. Now we had 3 morbidities, 1 male patient and 2 female patients, and we had 1 mortality. Among the first morbidity, we have a 25-year lady who underwent the excision for an axillary lipoma under local anesthesia. On the second post-op day, there was copious serous discharge along the incision line with no foul smell. The sutures were removed and the area was drained. This patient did not have any fever and the total count was also normal. Twice daily dressing was done along with packing over the next 3 days, and subsequently the discharge amount reduced. The patient was discharged on the 5th post-op day and with the follow-up advice of regular dressing. Second morbidity was a patient who was a 57-year lady who was admitted with the diagnosis of choledocholithiasis with cholelithiasis and underwent an open cholecystectomy with CVD exploration and T-tube placement. On the second post-op day, there was thick serous discharge from the wound from one particular site and along the wound line, and the sutures was removed and the site was drained. The sample was sent for culture sensitivity. There was no fever. The total count was normal. In this case also, we followed this up with twice daily dressing, regular dressing and cleaning of the wound over the next 3 days, and subsequently the discharge amount was reduced. Later on, the patient was discharged on day 11 after T-tube cholangiogram with a healthy wound site. The third morbidity was of a 62-year gentleman who underwent the Whipple procedure for periampullary carcinoma. The patient had a history of COPD with irregular therapy and a healed focus of Cox. The CBNAT was done and it was negative. Preoperative nebulization and incentive spirometry was started. Post-operative, the patient was also started on nebulization, incentive spirometry and chest physiotherapy. On the third post-op day, the patient was maintaining saturation at 99% on room air. Mild Krebs were present. But on the 5th post-op day, we saw that the patient developed shortness of breath with a sudden fall in SpO2 to 86% on room air. Following this, face mask was given and SpO2 improved to 99%. Bilateral Krebs were present and the patient was shifted to the ICU. Now in the ICU, a chest X-ray was done that revealed increased bronchoalveolar marking, and the shortness of breath improved with furosemide injection. The patient was shifted back to the ward subsequently after maintaining saturation overnight, and the patient was discharged with proper respiratory support advice. We discharged the patient after sensitizing him properly about the need for incentive spirometry, proper chest, after counseling the patient party regarding proper chest physiotherapy, and the patient did not have any subsequent respiratory issues. The one mortality for this month was a 38-year lady who was admitted with the complaints of recurrent subacute intestinal obstruction. This patient had a history of CA rectum and underwent LAR about 6 months back at a private nursing home. The ileostomy was closed around 2 months back, post which the episodes of subacute intestinal obstruction had started. For these episodes, conservative management was done. Later on, an enterocutaneous fistula was developed at the site of the ileostomy closure. The patient, when she came to us, was admitted with the primary complaint of subacute intestinal obstruction along with an enterocutaneous fistula at the site of the ileostomy closure. This patient was admitted for conservative management. Now, up till the day 10 after admission, the patient was improving. The discharge from the fistula site had reduced. The oral intake had been started and the patient was tolerating it, and the patient was also able to pass stool. Day 11 onwards, post-admission, gradually there was increasing abdominal distension. The patient's oral intake gradually decreased and the patient stopped passing stool. On day 15, the features of the patient suggested that the patient was in acute intestinal obstruction, and this patient was taken for an emergency exploratory laparotomy. Intraoperatively, dense adhesions were found and the distended bowel loops, and multiple metastatic deposits were seen on the entire bowel and mesentery. Adhesiolysis was done. The bowel was extremely friable and large areas of serosal bleeding were present. Resection of about 200 centimeters of ileum was done and proximal bowel was exteriorized. Post-operative, the patient on R1, the patient had a cardiac arrest. The patient was given CPR and ROSC was achieved. The patient was immediately shifted to the ICU where she succumbed after the second cardiac arrest, which took place around after 1 hour after the first attack. Thank you. Sir, you're not audible, sir.
In summary, you said there are 17 emergency admissions, but when you give the split up, you said 10.
Sir,
Go back.
yes, sir.
Summary. Yeah.
So we had, yes,
17.
So we had 17 admissions, sir, out of which 7 were taken for some emergency intervention, sir.
No,
And 10.
but 17, when you go to the next part, cases, when you give the diagnosis of elective emergency admissions, there I find 10 only.
Sir, the rest 7, so here the
Yes.
7 that were managed with some operative intervention.
Oh,
So these are the remaining 10, sir.
So your heading says emergency admissions. So emergency admission include all 17, and then some are undergoing operative intervention. And you see, torsion testis, you are mentioning elective admissions. As I said, even in the OPD, patient comes with some acute emergency, will be taken as emergency admissions. Okay, try to differentiate that. Emergency torsion testis will be emergency admission, even if he has come to OPD.
Okay, sir.
All admission in the OPD are not elective.
Okay, sir.
Okay.
Next, this patient didn't come like emergency patient. The torsion happened 4 to 5 days ago. Some local doctor managed him with.
What complaint he came to OPD?
Sir, he came to, sir, he came, no, sir, he did not come with, no, sir, he did not come with any such complaints, sir. This was a 12-year-old boy, sir, who did not have that characteristic pain of the torsion testis, sir, but he was having discomfort along with swelling. He had gone to a local doctor who had prescribed antibiotics and suggested an ultrasound. The ultrasound along with the Doppler stated that there was torsion of the testes and the blood flow had been lost. Already there was complete loss. This was, sir, around 2 days back before the patient had come. So then the patient was told to follow up at a bigger hospital, sir. And then the patient had come to us, sir.
Okay. The lady who operated with the axillary lipoma.
Yes, sir.
25 years lady.
Yes, sir.
So most of the cases I find these are not actually lipomas. These are usually axillary breast. How do you diagnose that as lipoma?
Sir, an FNSC was done, sir. Preoperative FNSC was done. The FNSC said it was a lipoma, and only then we proceeded with the excisions.
Okay. Otherwise, a good presentation.
Thank you, sir.
Siddharth, any comment?
No, sir, it's fine.
Okay. So you can pass on to the presentation by Unit 2. Dr. Prasenjit, you are ready?
Yes, sir.
Yeah, screen is visible.
Good morning, our respected faculty members and our I am Dr. Prosenjit Bosu. I am going to present surgical audit for November 2022 for Unit 2. There is summary which includes total OPD days 9, total admission day 10, and total OPD patient attended 1130, which includes old patient 446 and new 684. Total number of elective OT days 8, total time in OT, table 1 lab 30 hours and 30.
Not audible, Prosenjit.
In hepatobiliary and pancreatic splenic surgery in chronic calculus cholecystitis in lab coli, which includes total of 14 and 1 open coli cases. And in GI and perianal cases, fistula in ano, in which we did fistulectomy, and 1 hemorrhoids in which we did hemorrhoidectomy, and 1 fissure in ano case in which we did lateral ano sphincterotomy. In hernia and groin surgery, there is 1 case of inguinal hernia in which we did TAP, and 1 case of incisional ventral hernia in which we also did TAP, and there is 6 case of inguinal hernia in which did mesh hernioplasty, like and in 2 cases we did herniorrhaphy. There are some miscellaneous cases in which which includes a case of chronic appendicitis in which we did laparoscopy appendicectomy. There is 4 number of such cases, and in 2 cases we did open appendicectomy, and 1 excision of implantation dermoid, and 1 excision of corn, and 1 circumcision. And and 1 single case of pleomorphic salivary adenoma of parotid gland in which we did superficial parotidectomy, and there are some emergency cases like acute appendicitis, in which we did open appendectomy, and diabetic foot ulcer, which includes 10 cases in which we did debridement, and one single case of subacute intestinal obstruction in which we did exploratory laparotomy, and some minor operation, or we also did some minor operation which includes excision of hemangioma, excision of pyogenic granuloma, lipoma excision, and nail avensal in a case of ingrowing toenail paranoia and sebaceous cyst excision. We have one morbidity and one mortality in this month of November. Morbidity includes a 50-year female case of stump calculi gallbladder with known case of COPD, underwent open stump cholecystectomy, developed shortness of breath on POD1. Patient was managed conservatively with oxygen therapy, incentive spirometry, and chest physiotherapy and nebulization. Patient responded well on conservative management and subsequently discharged on POD5. One single case of mortality, which we have a 72-year female presented at ER with gross cellulitis and gangrenous changes on right lower limb with septicemia and AKI, associated with multiple comorbidities, that is hypertension, type 2 DM, hypothyroidism, ischemic heart disease. Patient was initially conservatively managed along with serial debridement and dressing, and later on we put the patient on negative pressure wound therapy for 7 days. Patient initial WBC count was 27,000, which responded well on conservative management and decreases to 14,000. But on day 8 of hospital stay, her urine output falls below 100 ml over 24 hours and SpO2 falls below 85% in room air. Patient is shifted to CCU and put on invasive ventilation on day 2 of CCU stay. Patient developed cardiac and succumbed to death.
Okay, keep the last slide. Keep the last slide, Prashant. This patient
Yes,
has infection with a total count of 27,000 on admission.
yes, sir.
When did you apply the negative pressure wound therapy? On which day?
Onset day 3.
Day 3. What was the count on that day?
On that day, sir, it's around 20,000.
So the patient has active infection. You should keep in
Yes,
mind
sir.
that one of the contraindication for putting NPWT is active infection. We should
Yes,
not,
sir.
the feature she developed sudden down of urine output indicates patient has got a systemic sepsis.
Yes, sir.
Okay, and one of the reason for this deterioration might be a systemic. What antibiotics she was on?
On Pibzo and metronidazole, sir.
Pibzometronidazole.
Later, yes, sir.
What bug this growth? You have sent the culture sensitivity.
Yes, sir. It is sensitive, sir. Pibzo sensitive.
What was the report? What other drugs it was sensitive to?
Sir, it is sensitive in colistin, imipenem, and gentamicin is also sensitive, sir, for this patient.
So what I'm saying is NPW2 can always wait. Initially, when the patient has an active infection, this patient needs debridement and dressings. Once you apply NPWT, one of the contrarian that is described is active infection is a contrarian you are putting the patient on NPWT. Okay.
Yes, sir.
And
Yes, sir.
go back to the surgery slide. Appendicitis is not a miscellaneous operation. Got my point?
Yes, sir.
You said miscellaneous is appendectomy. Why appendix should be miscellaneous operation? Appendix comes under GI.
Yes, sir.
And there is no term now called as chronic appendicitis. When the patient is coming to you in the OPD pain abdomen, the other patient has got recurrent appendicitis. The term chronic appendicitis is not used now. So these 6 will be either when they come to your elective admission, they might be having recurrent appendicitis. So that you have not given the split up of elective admissions. Go back.
So
these are the summary. Next. Okay. Then next. Then why GIT? GIT and perianal. The appendix should come here.
Yes, sir. Yes.
Recurrent hemorrhage patient should come here. Okay. Okay. Thank you, Prasenjit.
Yes, sir.
Diptaman.
Thank you.
Diptaman now will create problem. He's at home. Diptaman, on the class day, try to come to Bangalore by 8.
Sir, I'm already in outside Bangalore in the.
But it is 8:30 now. It's 8:30 now. It's your turn.
Sir, I am standing here for last 20-25 minutes. When you call my name, so
Okay, what I'm saying is, on your class day, at least be in the classroom so that there is no hitch in the presentation. Okay, it's now your turn, please.
Yes, sir. Hello.
Yes.
Sir, I'm
Diptaman.
audible?
Yes, you are audible. You start, please.
Good morning to my respected teachers, my dear colleagues and juniors. I am Dr. Diptaman Nandi. I am going to present the surgical audit for Unit 3 General Surgery, November 2022. Next, please. Next slide. In the summary portion, the total number of OPD days was 9, which included and also admission days 10. Total OPD patients was 1179, which includes new patients 851 and total old patients was 328. Total number of elective OT days were 9. Total time in OT 72 hours 42 minutes. Total number of minor OT days 19. Total number of mortality is 1 and total number of morbidity is 2. Now, little description regarding all the aspects. Elective admission was 61, which includes 31 male and 30 female. Emergency admission included 7, including 4 male and 3 female. Elective operation 48, 24 and 24, both male and female each. Emergency operation includes 3, in which 2 females and 1 male. Mortality 1, which is a female patient, and morbidity 2, which includes 1 male and 1 female. Now, in the detailed description portion, chronic calculus cholecystitis cases was total 17. It was operated, managed by laparoscopic cholecystectomy. Chronic calculus cholecystectitis, again 3, which was undergone open cholecystectomy. Inguinal hernia, 2 cases managed by laparoscopic hernioplasty, and 7 cases of inguinal hernia managed by open hernioplasty. Perianal fistula cases was 2 managed by fistulectomy. There is a combined case in our unit for uterine fibroids and chronic calculus cholecystectitis, which undergone laparoscopic cholecystectomy from our part, and abdominal hysterectomy was done by the gynae department. There was also 5 cases of diabetic foot ulcer, which underwent debridement and dressing. There is a case of hydrocele. Anal stretching cases were 2. Old septic perforation. This I will mention details later also, which undergone irrigation and drainage. Chronic pancreatitis case was 1, which undergone lateral pancreatic vaginostomy. Recurrent appendicitis case was one, which underwent open appendicectomy. Universal stricture was done. The senior person undergone pneumectomy. There is a basal cell carcinoma of nose, which undergone excision along with the support from plastic surgery department. There was a case of phimosis which undergone circumcision, and there are 2 cases of cellulitis managed with conservative therapy. Now with the continuation, bilateral inguinal hernia case was there, which was managed with TAP. Ventral hernia case managed with IPOM. Diamoid excision, 1 case. There is a case of soft tissue sarcoma which undergone excision. There is a case of biloma which actually was admitted in our unit for a prolonged time. Previously, it was operated and managed outside. Then she got admitted in our unit. Then she developed biloma. But in the month of November, she underwent here diagnostic laparoscopy, and there is drainage of biloma. This case was done here. Next slide, please. Regarding emergency admission, there is a case of septic perforation which undergone laparotomy. Acute appendicitis cases were 2 undergoing open appendicectomy. There is a case of ureteric polyp which undergone conservative management. Acute cholecystitis cases were 3 which undergone conservative management. There is a case of right luteal abscess which was undergone incision and drainage. Now these are some minor operations done in emergency OTs and also in our septic OT in the 8th floor OT. There are injection polycannulon, excision of sebaceous sheaths, about 11 cases, nail extraction cases, INDs, total 60 number. There are some granuloma excision 5 in number, and injection Kenacort was given in 4 persons. Now regarding morbidity and mortality, in the month of November, we have 2 morbidity cases and 1 mortality case. Next slide, please. Now some discussion regarding the morbidity cases. A case of cellulitis in leg with uncontrolled diabetes got admitted in male surgical ward. After regular dressings, antibiotic coverage, and anti-diabetic support, helped the patient to recover in a great way. Now, this is a senior male patient, which already he was having some uncontrolled diabetes pattern, not taking his medications regularly, and he developed cellulitis in home. And he came to our unit, and we admitted this patient. We consulted the medicine department, gave him a good anti-diabetic support along with IV antibiotics, and made some regular dressings with Maxalf and other things. And after a few days with regular dressings and this medication support, his cellulitis improved and he was discharged. Then the case number 2, a case of aged female with history of uterine fibroids and cholelithiasis, along with comorbidities of diabetes, hypertension, and COPD, got admitted and underwent combined surgery of laparoscopy, cholecystectomy, and abdominal hysterectomy. Post-operatively, this patient developed respiratory distress with decreased SpO2 and unstable blood pressure levels, for which he was referred to CCU. After regular monitoring in CCU for a few days and along with supportive management, he finally recovered. Now, this is the case which I have mentioned previously in the OT list. This senior female having this both combined surgery and gynecological operations, but she's already having some of these comorbidities like diabetes, hypertension, and COPD. And she was not taking his medications and this COPD treatment very enthusiastically. So after operations, she developed these problems. From the operative part, it was very much okay. There is no complaint regarding any operative part, but these comorbidities caused some problem to her. And for these things, she developed some morbidity, and these all types of supportive management needed to be given. But however, finally she recovered and went home. Now, this is the case of mortality which happened in our unit in November 22. This was a 62-year female admitted by emergency department in our unit with a 10 days old of history of septic perforation. Urgent surgical intervention done with peritoneal toileting and lavage, but no active perforating zone noted in that time. But within next 1 day, biliary drainage started from the drain output and which continued for the coming days. Patient was shifted to CCU for better supportive care. However, the amount of biliary drainage increased. Patient undergone another surgical exploration when a G1 perforation is noted along with additions. Perforation was required and peritoneal toileting done. She was again sent back to CCU for further supportive care. However, she later developed sepsis and multi-organ failure within few days and she finally succumbed. Now, actually, this patient was during in one of our admission days came to the emergency, which I attended, and after taking history from the patient party, I noted that the person was about 10 days old, and she had not taken any initial management and did not visit any medical facility. After waiting for 10 days, when her pain and this other problems was uncontrollable, she reported to Bangalore emergency. And we admitted that patient instantly and did this laparotomy. But that time we did not notice any perforation. But after this peritoneal toileting and drainage, we kept the patient to ICU. But her this biliary drainage continued and increased. So all type of support, even in spite of all type of supportive managements and other care, her status or parameters doesn't improve. So discussing with other teachers and seniors, we again made another surgical intervention, and then a D1 perforation is noted. But that ultimately didn't help her much because she later developed sepsis, and she was again sent to ICU and all types of supportive management and antibiotics, ventilator, even she was given, but that didn't help her, and ultimately she succumbed.
Diptavan, keep the last slide, mortality. Keep the last slide, yes. So you finally commented the second surgery did not help her. That is not the right comment. The point is you give a little more details about the patient. When there is death, you said coming days, within few days, that makes no sense. Okay, the point is you have a diagnosis of peptic perforation or perforative peritonitis. You did a laparotomy and no perforation was found. This can happen. This can happen in inexperienced hand, experienced hands. So you can miss because the 10 days old, there might be adhesions and the perforation area might be having flakes. So somehow it was missed. So what happened in the immediate posterior period? She was mentioned this, all these important points. She was draining 1.5 liters, 2 liters, and she did not have features of generalized peritonitis. But this continued for about 5 or 6 days. Then you decided that she must have some perforation that is missed. We decided to have a laparotomy. And this time of laparotomy, a clear perforation is found in the D1. And then subsequently, the drain output has gone down, but she started deteriorating. Okay, so death is a very, you just write a paragraph like this. You try to give the chronology of event that happened so that from this we have some analysis and see what was the thing that might have gone wrong and what you could have done. Okay, yes, make a chronology of events by putting arrows. Is few days, coming days are not important. Important is what happened in the immediate post-op period, what are their parameters. You not mention about the parameters. Was she hypotensive on the first or second day?
Yes, sir. She was hypotensive, sir.
No, she was not hypotensive. No, she was maintaining vitals also.
Sir, on the second day.
Sir, good morning, sir.
Second day, sir.
Yeah, Ganesh. Yeah.
Good morning, sir.
Yeah, Ganesh.
Sir, the patient initially came to the emergency with severe sepsis, hypotension. Her saturation was dropping. Her SpO2 was 74.
Yeah.
She was after doing the peritoneal toileting in lavage, she was initially doing good for 2 to 3 days, sir. The first POD, the drain was only 400 ml. POD2 also it was reducing. Suddenly, and POD3 it started increasing, sir.
Yes.
Around after POD5, the drain was around 1200 ml, sir.
Yes.
So on again after POD 10th day we opened it. After that peritoneal toilet lavage, again the patient was improving, but suddenly she deteriorated, sir.
And that is what I'm saying. Diptaman should give a clear chronology of
After the
events.
second
So
peritoneal
this
lavage,
is
the
a
patient
summary
was
which
doing
is
good for
not
2
the
days.
reflection of the patient course of event. So that is very important. You try to give the exact point is by audit, you want to analyze what has gone wrong, whether you could have done something to avoid this death. So going by retrospect, now I was feeling that these patients should have undergone exploration much earlier, because getting 400, 500 ml of drainage in a post-op patient where we have missed the perforation is an alarm that we have missed the perforation. There might be some perforation which is missed. And you see, on exploration, it was found that there is a small perforation in the D1, which is covered by flex. Okay, so these are all important. And Diptaman, go back to your analysis of the admissions. Why you are so haphazard? Everyone is presented with the hepatobiliary, GI. You are so haphazard. Wait, conicolicitis, then angular hernia, then diabetic foot ulcer. Why? Why not make a chronology of groups? Next slide. Hydrocele. We don't do anal stitching for anal fissure. The operation is not anal stitching. Operation is lateral anal sphincterotomy. And here you put basal cell carcinoma, urethral stricture, chronic pancreatitis. Why are you so haphazard? We have a pattern of presentation of audit with systems, GI, hepatobiliary pancreas, colorectal, then breast endocrine, and then come miscellaneous. Okay, these are not proper way of presentation. Try to understand. You are presenting for last 3-4 months. You should understand how the it will be presented. Next. Again, your hernia. You have mentioned hernia below gallbladder, and again you are bringing hernia here. Why? Then biloma. Biloma patient should have been given in more details. And this patient should have been under your morbidity. What happened following? Why has the biloma happened? Is a post cholecystectomy, post cholecystectomy CBD injury, presenting to us with biloma. And what we have done? We have done laparoscopy and put a drain. And what happened in the immediate post-op? This patient is having morbidity. She had continuous bile drainage for about next 10-12 days. And then the biliary secretion came down and we removed the tube. We did a ultrasound. We find there is no collection, and then she was discharged. As such, we cannot localize any biliary injury on second lavage. And this lavage was by laparoscopic drainage. Okay, so this patient should come under morbidity. Okay, right? Make a better presentation for the audit. Okay.
Okay, sir.
Any comment from any of the faculties? Abhishek, I find you did a TAPP for a ventral hernia. What you did is a classical TAPP by putting the mesh in the retrorectal space by lifting the peritoneal sheath.
Yes, sir.
So you put
we raised a peritoneal flap, reduced the sac, and put a mesh, sir.
What, polypropylene?
Yes, sir.
And
then close the peritoneal flap. Yes.
You close the gap also in the anterior sheath?
Yes. With the barbed sheath. Yes.
Good. That is a good procedure. You save money for your mesh, and then, but it takes a lot of skill for suturing. Yeah. Okay. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you.
Thank you.
Thank you.
Thank you, sir.
Thank you, sir.
Thank you.